It's a hello to the COVID scientists and the COVID warriors. It's a good afternoon and a warm welcome to all the speakers and participants. I am Dr. Subhash Hira, a doctor of infectious diseases and a public health scientist. I am moderator of the webinar learning series that is launched by the Global COVID-19 Network. This global network is launched because COVID-19 is a pandemic, and the best way to respond to this pandemic is to bring the global actors together. Thus, Sambodhi Research and Communication Organization, Indian Social Responsibility Network, New Delhi, and the University of Washington, Seattle have co-sponsored this global network to foster South-South collaboration and partnership to share lessons of COVID. Mr. Sudhanshu Balotra of Sambodhi and Mr. Santosh Gupta of ISRN are also connected with us today, and they will be able to interact during the question answer sessions. So as we begin, the world case count of COVID-19 has now recorded over 4.5 million infected people, and just over 320,000 people have lost their lives. That is the fatality rate of 6.5%. I will be brief to recap the third webinar held on 12th May 2020. Honorable Vinay Sahasrabudheji, member of Indian Parliament, spoke last week about Indian responses to the pandemic that included the national lockdown since 21st March. That's about 58 days since 21st March 2020. That flattened the curve of new corona cases and kept a low death rate at around 3%, and of course, several social steps to support livelihood. The locally made testing, diagnostic tests, pharma supplies, and PPE have eased management of cases. Our second speaker, Dr. Por, Deputy Director of Institute of Public Health in Cambodia, spoke of selective lockdown in that country, and it spared the local travel, the local markets, and the restaurants. Early shutdown of international travel actually helped the country to keep the curve of infection flat, and 0 cases have happened since late April. Their schools and educational institutions are still closed. Dr. Sarman Singh, well-acclaimed immunologist and microbiologist of India and director of AIMS Bhopal, he spoke on technical knowledge on testing methods and their validity and intermittent shedding of the coronavirus, raising false alarms of reinfection and relapse. He stated that the Ministry of Health had announced that all districts in India will soon be having gene expert tests to diagnose coronavirus infections in all the districts, since gene expert machines and the trained lab staff are already present in districts in India. Patients are now being discharged in India at 10th day of onset of symptoms instead of 14 days. Camila, can I have my first slide? That's the only slide. I will take a minute to explain the clinical stages of COVID that occur in 15 to 20% of symptomatic cases, as shown in this slide. The slide on the left shows stage 1, which is the viral response phase. It is during the 0 to 5 days with mild symptoms or illnesses like fever, dry cough, diarrheas, and headache, and shivering, and lots of smell and taste. Stage 2 is the lung phase, that is around 4 to 14 days. And that's the time when illnesses like breathlessness, extra changes, and low oxygen below 94% saturation. And then the stage 3, which is the hyperinflammation phase of a storm that happens due to the hormones called interleukin. It's basically a swelling that happens into the vessels and various organs like the heart, the kidney, the lungs, and produce clots in the vessels and heart failure and stroke, etc. So, with this background, our fourth webinar is today discussing treatment and vaccine development for COVID. So our first speaker is Dr. Prashant Saxena, Head of Critical Care at Max Smart Hospital in Saket in India. He has a first-hand experience managing and treating corona patients. Since the mixed audience that is watching this webinar live on Facebook and Twitter that is exceeding 2,000 people at this point, our speakers have decided to use simplified medical language. So it's over to you, Dr. Saxena.
So if we have a suspect of COVID in the flu clinic or emergency or OPD, then we have to do the test of the patient. And if the test is positive, then we categorize the patient as mild, mild with risk factors, moderate, severe, and critical on the basis of this chart. Now, a mild patient is a patient who just has fever, cough, and minor symptoms of flu. These patients, as per the Indian guidelines, are eligible for home isolation. You don't have to admit them. But if the mild patient has risk factors like age more than 65, diabetes, hypertension, immunosuppression, transplant, these are the patients whom you would like to observe in the wards. Similarly, we have moderate, severe, and critical patients. Now, these are classified on the basis of increasing severity. Increasing severity means increasing requirement of oxygen, increasing chest X-ray worsening, and increasing involvement of other organs which may gradually succumb to the COVID infection. So on the basis of these, we have moderate, severe, and critical. Mild and moderate patients can usually be managed in the wards, but as far as the severe and the critically ill patients are concerned, they have to be managed in the intensive care setting. So as a general guide, there are few indications for hospitalization for general interest. I would like to highlight these, that anybody with a COVID infection with a respiratory rate more than 24, saturation coming below 94, confused, drowsy, or a PP is not normal, it is low, or has a comorbidity including age more than 65, cardiovascular disease, diabetes, and chronic lung, liver, or kidney disease. These are the patients who may require hospitalization. Once you have the patient in the hospital, then we do the usual tests which are recommended. Plus, we have a risk stratification, which means we send a few set of parameters which tell us that if these parameters are on a higher level, the patient has a higher risk of developing complications and a higher risk of dying from the disease. These include D-dimers, ferritin, LDH, troponin, and ECG. So these are the basic tests which we do. X-ray is mandatory. You don't have to do a CT scan all the time unless you are suspecting some other illness. So as I told you, mild are the patients who have very mild symptoms. These are the patients as per Indian guidelines who can be monitored at home. And if they are admitted to a hospital because of comorbidity, or if they have a concomitant diabetes or immunosuppressive disease, then you just monitor these patients and they are discharged on the 12th day if the test of COVID is negative, as far as the Indian guidelines are concerned. If the test is not negative, we intend to keep them in the hospital till and repeat the test every 2 days till the test is negative. Similarly, for patients who are mild but have risk factors, we try to maintain oxygenation. I told you 94% saturation is our basic standard, and we want to maintain oxygen at this level. fluid may be required, and similarly we give mild antitussives, antipyretics, and they may require sometimes inhaled therapy. But remember, we tend to avoid nebulization in these patients because there is a risk of aerosol dispersion. So we try to manage these patients with inhaler and a spacer as compared to a nebulizer. Now, these are the patients who may require treatment. As you are well aware that in India we are using hydroxychloroquine, which is known as SCQ. It is given along with azithromycin. Azithromycin is an antibiotic, and it has been shown that if you combine both, then the killing of the virus is speeded up. Along with it, we are using oseltamivir. Now, this is a drug which we use for flu, H1N1 swine flu. Because in India, we have a mixed population. Sometimes you can have a dual infection. You can have a COVID along with H1N1 infection. So we start empirically because both the clinical features are common. And once the H1N1 is negative, we stop the oseltamivir. Other drugs are available. If the patient is intolerant to SCQS, then we use a combination of lopinavir and ritonavir. And important thing is to monitor the toxicities. Please remember, you do not administer lopinavir ritonavir combination with SCQS. So you are not combining the drugs. It is either SCQS or lopinavir ritonavir. Then for severe patients, now these are the patients which are most concerning. These are the patients who are in the ICU. These are the patients who have a high risk of complications. These are the patients who are the 5% of the lot which can die. We usually start with supportive care. We are using all the precautions to avoid aerosol dispersion, which means we don't want the patient to transmit infection to the healthcare providers. We are managing them in negative pressure rooms. We are using ventilators. Important thing to remember in these patients is that the standard drug which is recently recommended by the US FDA, remdesivir, we are using in these patients, but in some centers it is not available in India. So again, we are using a combination of hydroxychloroquine and azithromycin. If you are not able to use hydroxychloroquine or chloroquine, then we are using a combination of lopinavir, ritonavir in the given doses. Now, this combination is long available in the Indian setup. It is a drug which is used for HIV treatment also, but we are using this for the treatment. Chloroquine, a lot of debate is there, whether it is beneficial, whether it is not beneficial. I can tell you there is no conclusive evidence, but in vitro studies have shown, in vitro means studies which are conducted outside the human being, have shown that they reduce the viral shedding and hamper the step of viral replication. So as of today, we are using this drug as first line for patients who have COVID positivity. The problem with the chloroquine is that chloroquine is a cardiotoxic drug. Apart from being gastric intolerant, we have to do a baseline ECG. So ECG daily is a must. If there is a problem in the ECG, we measure a interval known as QTC interval. If it is high, then we stop hydroxychloroquine and tend to give the other medicine. Please remember, if you are combining hydroxychloroquine and azithromycin, which we are doing in our setups, we have to be very cautious because both of these agents can increase the QT interval, and you have to be very careful when you are using these drugs. But so far, I can tell you, they have been very safe. We have had few patients in which we had to discontinue the therapy, but generally it is very well tolerated. Azithromycin, as I told you, you should not use azithromycin alone. It is an add-on to the hydroxychloroquine because it has been shown that there is an increased reduction in the viral carriage if you are using the combination. Coming to lopinavir, ritonavir, I have told you if your patient is intolerant to hydroxychloroquine, there may be many who have complications, then you have to use this combination of lopinavir, ritonavir in these patients. It is available in India also, and we have also tried this. Coming to remdesivir, the much talk about drug, and the US FDA approved it, and it has been recommended for compassionate use only because it's an expensive molecule. The only thing is that it has got hepatotoxicity, but the dosage is as given in this slide, and it has to be given for a total of 10 days, and it has been shown to be effective in reducing the severity and improving the patient faster. So this is the combination which is being evaluated. A lot of trials are going on, and the patients are already on this medicine. Oseltamivir, I told you, it is a H1N1 swine flu drug. But in India, because we have co-infections with COVID plus H1N1, so we are starting this drug empirically. And if the H1N1 test is negative, we are stopping this molecule after 24 hours if the test is negative. Then, as Dr. Hira mentioned, the cytokine storm, we know any inflammation in the body incites an immune response, a cytokine storm, and in COVID it has been seen that there is a cytokine storm which is modulated by T cells and inflammatory monocytes. These T cells and inflammatory monocytes, they gain access into the pulmonary circulation, and they reduce the transfer of oxygen inside the lung. So that is the main problem with COVID. That's why the severity of the illness is so troubling that most of the patients are dying because of oxygen debt. Oxygen is not going inside the body, and this is the reason the cytokine storm is responsible for it. We have medicines to our armamentarium. One of the important ones is tocilizumab, which is an interleukin 6 inhibitor. Interleukin 6 is a major inflammatory mediator responsible for the problems in the lungs which are caused by cytokines. This drug has been shown to stop the action of interleukin 6 on the lungs. And the problem is hepatotoxicity, so we have to monitor liver functions, but it is being used in our severe patients and we are using it. Coming to hemoperfusion cartridge, now this is something which has been used in the past. Now these are, it is like a dialysis. You have to dialyze the patient and use a filter which is known as a hemoperfusion filter. This filter is made of a material which tends to absorb the cytokines and returns the blood which is purified or removed from cytokines to the patient. So it's like a dialysis with a filter which is removing the cytokines. There is a protocol for it, and I will not go into the details, but it has been used as a temporary measure to stabilize the hemodynamics and oxygenation of these patients. Another important and much discussed therapy, which is convalescent plasma. And we all know if a patient is recovering or has recovered from an illness, the patient tends to develop antibodies in the blood. So the thought came that why not transfuse these antibodies after matching into the patient who has the disease, and they may fasten or improve the patient faster. This therapy has been tried in the previous infections of Ebola and the MERS, SARS coronavirus, H1N1, all the epidemics and pandemics in the past. Plasma therapy has been tried with variable success. There were positive reports. So now in our severe category of patients who are deteriorating, who are not showing improvement in oxygenation despite usual therapy, we are using convalescent plasma. Now it is difficult to get plasma because you need a donor, you need a patient who has recovered. So the challenges are there, but we have seen enthusiasm in the public, and we are encouraging more and more plasma transfusion and trials to evaluate it, but initial results are showing a positive trend. Corticosteroids, a much asked question, do we use steroids? See, there is no major study, major trial in the previous epidemics of viral illnesses which have shown a positive response with steroids. So steroids should be reserved in patients with refractory hypoxemia and refractory shock, which means the patients who are severely ill of COVID, we are tending to use steroids, but otherwise we are not using them. Vitamin C, it has been shown in many studies that vitamin C has shown to reduce mortality in patients of these viral infections, and we are using a moderate dose of vitamin C, 1.5 gram every 6 hourly, and combining it with thiamine. And the cocktail has shown to improve the results in patients of these illnesses. And but there is no high quality evidence. But till the time we have evidence, the little bit of evidence we have is sufficient enough to enable us to use it, and we are using vitamin C and thiamine combination in all our patients who are admitted into the hospital with this illness. Antibacterial therapy is not indicated. You don't need to give antibacterial antibiotics, but remember that viral infections can have a delayed superinfection. So a watchful eye, a daily assessment of the patient, worsening infiltrates, increasing oxygen requirement should guide you to add antibacterial therapy, but it has to be individualized and it has to be an expert who can decide on this. There are other agents. I will not go into the details. So many drugs which are undergoing trials for use in COVID, and in many US centers, these trials in Italy also, the trials are undergoing of these medicines, and we have to wait for the results to come. Then important issue is coagulopathy, which means patients of COVID, we have seen they tend to clot easily. And this is one of the major problems we are facing, that these patients are dying because their blood is clotting. Blood is clotting in the heart, causing heart attacks. Blood is clotting in the lungs, causing infarctions. So it is wise to do some tests which let you know that the patient has a tendency to clot. And on the basis of these tests, we add molecules which prevent clotting in the blood, which is known as thromboprophylaxis and anticoagulation. And we are using it in many patients, and we are doing D-dimer assay at the start of the treatment along with other coagulation markers to guide us. Ventilatory management, I will not go into the details because it's very expert driven, but let me tell you that we have expertise. The world knows that severe ARDS or patients who are in severe respiratory failure, we have got ventilatory management strategies to deal with these kind of patients, which include your high flow nasal cannulas, prone ventilation, and expert management of ventilator to enable them recover fast from the ventilator. ECMO, which means extracorporeal membrane oxygenation, which is again taking out blood from the body, oxygenating the blood and giving it back to the body. So you are artificially oxygenating the blood through this machine and returning back to the patient the oxygen rich blood, because we know the lung is incapable of absorbing the oxygen. So this is a life-saving therapy in patients with severe form of ARDS and refractory cardiocirculatory shock. And this is reserved for very few patients. And let me tell you, so far we have not used it in any patients because either the patient was too sick to even, this requires a lot of training. You need to put cannulas. So we didn't get the time, but it is a therapy which is useful if you decide to use it early. So this is the end of my talk, and I thank you all once again, and I'll welcome any questions.
Thank you, Dr. Saxena. It's a very good presentation. We will have the two clinical speakers answer the questions together. So we will request Dr. Debashish uh, Gupta. He's professor and head of Department of Transfusion Medicine at Sree Chitra Tirunal Institute of Medical Sciences in Tiruvananthapuram, Kerala in India. One of the pioneers doing the convalescent plasma therapy. So it will be good to have you take over from here, Dr. Gupta, and then after you finish, then we will go into question and answer sessions on clinical before we go on to the vaccine thing. Thank you.
Good evening, everybody, once again. And I'm going to talk in the next couple of 15 minutes about the convalescent plasma therapy, which has been given to me because I started this therapy in the state of Kerala. I'm coming from the Kerala, which is the southern, it's a state in the southern part of India, and it's called as God's own country because it has abundant of natural beauty. But of late, there's a panic among all the people, and this nature has been overtaken by the onslaught of coronavirus. And this is the first state in India which has reported the first case back on 30th of January. So there might be some repetition of the talk because as I've heard from Dr. Subhash and Dr. Prashant, so that I'll try to overcome all those repetition, not try to go much into details. So the first case, as we all know, was identified in the Wuhan province of China in December 2019. Suddenly, there was caused by identified as severe respiratory syndrome coronavirus 2, and from then it has been spread across the globe, and it has now become a worldwide pandemic. If you see the global scenario as on 18th of May 2020, there's around more than 4.8 million people are affected with the COVID-19. And while the mortality has been reported in more than 317,000 people, then the recovered, though there's a recovery cases around reported to be more than 1.8 million. Under this situation, what can be the possibility of the treatment of COVID-19? Just now, my previous speaker, Dr. Prashant, has given a very brief information about the treatment modal protocols which they are carrying out, and these are also being carried out in various parts of the globe. But still, as he has also mentioned in his talk, that all the modalities are not accepted because besides this, there's no approved vaccine available. There's no specific antiviral therapies there to treat COVID-19. And for that, the type of management which we can, which is involved nowadays, is the isolation of the patient, which is in the quarantine. We have to go for symptomatic treatment, the supportive care in the form of the supplemental oxygen and mechanical ventilation, and experimental measures like antiviral drugs, antiretroviral drugs, antibiotics, hydroxychloroquine, and convalescent plasma therapy. These all have been mentioned by Dr. Prashant in very nice and superlative way. So now my talk will be concerned only on the convalescent plasma therapy. So what is this convalescent plasma therapy? Why there's so much of talk going on across the globe that there's what is convalescent plasma therapy and how it can be effective in treating this COVID-19 patient? So it is not a new concept, convalescent plasma. For the last many decades, a trial has been done with this convalescent plasma in many diseases like MERS, SARS, chikungunya, Ebola, some with very good results and some with limited results. So the rationale for this particular treatment that a patient who have that infection, he develops antibodies to that particular infection, and that antibodies will be taken, will be withdrawn from the patient plasma, who is now recovered, and this can be used as for the passively infused into a patient who is already now infected, and thereby it can cause a passive immunization on the patient. There are some studies are available from China, from other countries also, where this convalescent plasma has been attempted in a very selected number of cases and with very encouraging results. This one study which has been done in China, where there's a series of only 4 patients, and including one pregnant woman also there, and they had received this plasma therapy, and all of them recovered eventually. There's another very big study of the 10 affected patient, severely affected patient. This was a study from China. They also found that with the transfusion of 200 ml of this convalescent plasma, that the patient recovered within 3 days, and there is a total disappearance of viremia within 7 days. So this was a really challenging, and this has brought some sort of ray of hope among the medical fraternity to start and see that how this can be used as a treatment modality. If you see the Indian scenario, as of today, the reported case of COVID-19 in India has crossed the 100,000 mark, and more than 3,000 patients has died due to this disease, and there's now more than 57,000 are now active cases of there, and we have 39,000 plus cases who have recovered from this patient. Now our target is this 39,000 patients who have recovered from the COVID-19. They can be a subject for the convalescent plasma donation. So when we go for the convalescent plasma therapy, there are 2 stages. First stage is the recruitment of the plasma donor. Who are the person who can be considered for the donation of this plasma. And second part is where the identification of the COVID-19 patient and who can be eligible to receive this convalescent plasma therapy. So these are in 2 phases. So we have to see that how we recruit the right person to become a plasma donor, and we give the right patient the plasma therapy. So the entire thing started from the recruitment of the donor of a COVID-19 patient who is on the way to recovery. So at the time of the discharge, there should be some person assigned to motivate the donor, who is patient, I would rather say, that his plasma is now contain the antibodies to this COVID-19, and he may become a plasma donor, so which can be very much be helpful in treating the patients who are suffering now from COVID-19. So though we have known that we have now more than 35,000 cases of recovered COVID-19 patients, but all of them are not eligible to donate. There are certain restrictions are there which we have to follow as per the Drug and Cosmetic Act of India, which is a regulatory authority in compared to the US FDA. So, if it is a donor, the donor must be more than 18 years of age. So any children who have suffered from COVID-19 and recovered, we cannot take them as the plasma donor. Then the male or the nulliparous female who weigh more than 55 kg should be a subject. So anybody less than that cannot be a subject for a plasma donor. So prior diagnosis of COVID-19 should be there, and there should be a complete resolution of the symptoms at least 28 days prior to the collection of the plasma. So, or if you want to take 14 days before that, then at least 2 consecutive nasopharyngeal swab tests should come as negative for COVID-19. Then only these people will be eligible to come forward for plasma donation. So how we can screen this eligible donor? Even they have recovered from the COVID-19, but still we should maintain all the PPE measures while examining the donor. And donor not fit for donation and will be deferred and excluding from this donor pool. And any donors who had received any transfusion in the last 8 weeks also should be deferred from donating plasma. like the normal healthy voluntary blood donor, this who comes to the blood center only once and they get tested and they get screened and they donate the blood or plasma. It is different in this case. They have to make a 2 visits. This is totally different. The first visit is for going for certain pre-donation test, which is highly recommended, and every donor has to pass through these tests. And second visit, he has to come to the blood center for collection of the blood convalescent plasma or the plasmapheresis. So in the first visit, when the donor comes to the lab, his blood sample is withdrawn and the stipulated testing has been done like the normal donors which will go through it, like the ABO grouping, RH typing, antibody screening, then the screening for the TTI transfusion transmitted infectious markers like HIV, hepatitis B, hepatitis C, then the syphilis and the malaria. And if they are found to be negative for all these markers, they are eligible. But besides that, we have to do a complete blood count, including the hemoglobin, hematocrit, platelet count, then the liver function test to see the protein levels, because these tests are not being done routinely in the normal healthy donors. But we have to carry it out, as Dr. Saxena has highlighted in his talk, that they have some changes in the coagulation profile as well as in the liver and the other multiple organ involvement. So those things should be within the normal ranges while we select the donor. Besides that, we have to see the presence of the IgG and IgM antibodies to the COVID-19 and the neutralizing antibodies, because these neutralizing antibodies are very important for the beneficial effect of the convalescent plasma therapy. There should be a titration of the anti-COVID-19 antibodies, and its desired titer is considered to be 1:1024, and for IgG antibodies and neutralizing antibodies is 1:40. But this test is not available in many of the centers in India. So what is the other alternative? How we can ensure that this high titer we can achieve from a donor? So the easiest way is that don't take the blood from the asymptomatic donor, asymptomatic patient or the mild patient who has recovered, because their titer may be very low. Those patients who had a serious disease and they have recovered from the, ultimately recovered from the disease, they might have a high neutralizing antibody titer. So those patients should be our target. And if it is not possible also, then also attempt can be made. We can collect the sample, we can store it for a time, and then whenever the facilities are available, we can conduct this test. But my main information to all the people is that try to select the donor in a very rational way, so that we see that this particular donor might be having a high titer of neutralizing antibody as well as IgE antibody to COVID-19. So the second visit, this is the first visit where the tests have been done, carried out, they found to be okay, and they have been selected. Now they have been asked to come on a particular day to donate their convalescent plasma, as in the form of the plasmapheresis. Usually we should not go for the whole blood donation. Though the whole blood, if you donate, and we can separate the plasma, but what happens here, the red cell has to be discarded, because this particular donor doesn't qualify as a normal healthy donor. We have to remember this thing. So the best alternative is to collect the plasma only by the method of plasmapheresis. It has an added advantage, is that you can collect a volume which can be divided into aliquots and can be treated for more than 2 or 3 patients also at a time. So with one donor plasma, 2 or 3 patients can be benefited. So the volume of the plasma it depends upon from center to center, but it should not exceed 1000 ml in a per sitting. And whenever we are doing the extracorporeal volume, should never exceed 15% of the total blood volume. So the care has to be taken that these are being followed. And once the plasma is being collected, they can be frozen at minus 40 degree or below, and you can store it for 12 months. There are certain now questions that that many states now they have less number of patient and less number of recovered patient also, or there are certain cases where there is high number of patient and they don't have the requisite donor. So whether this particular plasma which is collected from one state can be transferred to the another state through proper cold chain transportation. So those things has to be exploited and has to be encouraged. So as per all the studies has been done, they found that one dose of 200 ml of convalescent plasma is sufficient enough to treat a patient. But sometimes in the most very severe cases or life-threatening diseases, we may be requiring a second dose of 200 ml of plasma, and this has to be seen by monitoring the patient from day 1 to day 28, how the patients are responding. So that part which I have just told is a part of the collection of the plasma. Now, what we are going to do with this plasma? Whom we are going to transfuse to this plasma? Which patients are eligible to get this plasma therapy? So we have to determine the eligibility of the patient for this CP therapy. So the patients, we almost should have a confirmed laboratory diagnosis of COVID-19, and we must ensure that instead of giving the CP therapy to the asymptomatic or milder cases, we must try to transfuse this patient plasma to those patients who are severely affected or those who have life-threatening diseases, as explained by Dr. Prashant. So then this will be much more in a better way we can manage the patient who are having active disease. But the foremost important thing is that we have to take a informed consent from the patient, or if not possible, to the next of the kin. So certain investigation and follow-up has to be done to see the efficacy of the convalescent plasma therapy. So this enrolled patient will undergo examination and certain investigation pre-transfusion as well as post-transfusion. The post-transfusion follow-up should be done on day 1, day 3, day 7, 14 and 28 till he is totally resolved from the disease. So how we do the monitoring? So the patient has to be monitored before the transfusion, plasma transfusion, for the signs and symptoms, whether he's having fever, cough, shortness of breath, the presence of any comorbidities, as already explained by Dr. Prashant. The vitals have to be monitored, and whether the patient is receiving any medications as given by the list by Dr. Prashant, or whether anti-inflammatory drugs, any antibiotics, hydroxychloroquine, any antiviral drugs, or anti-HIV drugs. So those things have to be seen, and accordingly we have to categorize. So these are the investigation which we have to do while we are doing the monitoring the outcome of the convalescent plasma therapy. It starts from day 1 and it goes up to day 28, where we have to do the complete blood count, the CMP, the LFT, the C-reactive protein. Then we have to do the arterial blood gas analysis, the coagulation profile. Those he has already explained that there are maybe some coagulation abnormalities will be there. So we have to do the coagulation profile of the patient. Biomarkers like ferritin, D-dimer, LDH. Then the interleukins. Interleukins 6 and 11, since there is a storm of cytokines, so we have to ensure that whether they are coming down. So it is usually done in day 3 and the other day 1, and it is not done to be regularly. Then we have to do the SARS RT-PCR to whether the viremia is coming down, okay, and whether the patient has been free from the viremia. And of course, the imaging has to be done of chest X-ray to see if there's any significant changes in the lung field is being observed. So, what is the current status of convalescent plasma therapy? I'm from the state of Kerala, and we are the first state, because the first case has been reported from Kerala, and the ICMR, we got the nod from ICMR to explore plasma therapy on April 9th to 2020. And from after that, we started gearing up all the logistics to see that how this thing can be started. So now ICMR has come into the picture, and they have initiated a multi-center clinical trial, phase 3 open-label randomized controlled trial to assess the safety and efficacy of the convalescent plasma. So as of 11th May, they have given approval to 76 centers across the country for conducting this classic trial. So this is how we can go to the online and we can register ourselves with ICMR for starting the trial, and we can in this way, and we can go for the approval. Once we put on the online this thing, we can get an approval from the ICMR, and DCGS approval should be also be in there. One of the most important approval is from the Institutional Ethics Committee. That no trial should go without a ethical clearance from the institute where you are performing the CP trial. So in Kerala scenario, I'm giving the latest on the 18th May, that is yesterday, we have around 631 reported cases of COVID-19, right from the first case which was reported on 30th of January 2020. We have now 631. We have got a very good control over the pandemic, and it was almost controlled. But of late, the last 1 week, there's sudden spurt of the number because of the deportation of the people from the other countries back to India. So this sudden spurt of some cases has been observed, and now we have 130 cases of active cases of COVID. But our now target is 497 people who has recovered, though the mortality is very low in state of Kerala because of the very good healthcare facilities. Now, in this 497, we have approached many recovered patients, and we saw a very good response from the people who are coming forward for plasma donation. But since now the number has gone up, it was actually 1 week back, it was less than 20 active cases were in Kerala. Now it has jumped to 130. So we have more cases now, and then this CP therapy will become more effective when in starting. So now to conclude, since it is under the clinical trial by ICMR, so the reports are being awaited from all across the country to show their efficacy of this therapy, and it should be submitted to the ICMR at a later date. And I think then it will be open to all the things that how it has taken, how the beneficial role has been observed in those cases of the COVID-19 patient. So along with this present modalities of the therapies which are being attempted in the patient in the form of the various medications, ventilation. So we required a lot of research has to be carried out to see the efficacy of the convalescent plasma therapy. And we have to see that whether it is having a really beneficial role in controlling this disease and bringing a very sea change in the medical management of the patients. And they are all looking forward for it, because getting a plasma from the donor is not a very hard task. It can be achieved, and we are very much optimistic and looking for the coming days where this therapy will become very much fruitful and can save a lot of life. Thank you.
Thank you, Dr. Debashish Gupta. Excellent presentation, both on clinical, Dr. Saxena as well as Dr. Gupta. There have been several compliments that have come across, several. I may not be able to name all of them, but there is Mr. Baduria who complimented, then the Deputy Examination Controller of Assam Kaziranga University, Dr. Palab, and then you have Chandan Datta and several other dignitaries. There are about 1,600 people who are watching this presentation live on Facebook as well as Twitter. Yes, Ajay Sharma, also the founder, is complimenting. So I think everybody is very happy that these are good presentations. Some questions that have immediately come across, and that is coming from the ISRN chief, Mr. Santosh Gupta, asking that between the two clinician professors, the Dr. Saxena and yourself, have you seen any reinfection cases so far in India? And in Kerala, you are the beginners of these cases that you saw. So once they are cured, the question they are asking is, once a patient has got 2 negative RT-PCR tests after going through the illnesses, and have you actually seen a case of reinfection, or
Yeah.
are these irregular? Yeah.
Means relapse of the disease, you mean to say. The relapse, again the patient get infected.
Yeah, either reinfection or relapse.
Yeah, we have not seen a single case of the patients who have recovered and again showing positivity at the later date. We are all came to negative, and they have all come back to, some of them which are still in the quarantine period because they are recovering from over a time. So 50% of the patients are still in the quarantine after the recovery. But those who have crossed the 28 days of time, now they are have back to their own self, and they are quite doing their normal activities.
But it is possible to have a reinfection. Yeah, I can only add to this because it's a viral illness and it can happen again and again, though the severity may be less because you will have antibodies developed inside you, just like a flu, which comes every year. So there's a possibility that there can be a reinfection. But so far in India, we don't have major reports about this.
In Wuhan, following the initial period that they went through. So I think the relapses could happen. I mean, these are all possibilities, but right now I think it's not the issue that should bother the national programs at this point. There's another question Mr. Santosh Gupta, the chief of ISRN, is asking is, Dr. Debashish, what is the success rate of your plasma therapy?
The success rate means we have given to 4 patients and they are all recovered. So we are not able to give more because, and now with the recent spurt of the thing, we have to again see attempt the CP therapy and see that. But whatever we have given, they are all recovered and now they are all doing good. And we are monitoring them with all the investigations, and their hemoglobin C reactive protein has come down, their lymphocyte level, the interleukin has come down. So we are monitoring the chest X-ray is showing very clear picture. So those things we are keeping a track of.
Excellent. There's another question related to the same thing is, how many times can a cured patient of COVID-19 can donate plasma?
And there's a lot of debate also there. But actually, I'll tell you, like a normal healthy donor who donates plasma, they can donate every 2 weeks interval. Okay, normal 2 weeks, and they can donate maximum based on their body blood volume and the body weight. They can go to the maximum 1000 ml. But in our country, we have a guidelines which says what doesn't permit above 500 ml of plasma. So that is our guideline, Indian guideline. But in other countries, they can even collect up to 1000 ml. Now they can donate in a gap of 2 weeks. But here, since the liver functions tests are being abnormal, the serum proteins are also in question, we have to see that we don't do repeated donation from this patient. So In total, in a year, a donor can donate 12 times, okay, of plasma. But whether here we want to see that whether this patient can be taken up to 1 year, or it can be maybe in a period of 1-2 weeks, we can take 2 collection, provided he can tolerate well. Okay. So that also we have to, because they are not a normal. We have to think about that. They have achieved normalcy, but they are not still now full healthy.
Your colleague, speaker Ernesto, is put in 2 questions. And Dr. Ernesto is asking, how many patients have you treated with convalescent plasma in Kerala or at the 76 other approved centers? Just maybe a ballpark figure.
I can't say about the other state because it is totally a ICMR clinical trial. So what they are doing it, but in our Kerala we have attempted a total 4 patients which have gone, and because by the time the more of the people got treated and they came out from the thing. So it is other state. I just cannot give the thing. I think Max can give information because they are also into the convalescent plasma therapy. Dr. Prashant can highlight
so,
a second.
So we are part of the trial, sir. I can only tell you that we have used it in close to 20-25 patients till date, and it's a beginning. And the results are, I can tell you, are encouraging. I cannot give you the exact details because I am not, I cannot share this information at this stage. It's too early because we have not analyzed the data. But I can tell you the success of plasma therapy depends on when you have started the therapy. It is always wise to start the therapy the moment you judge clinical deterioration in the patient. Otherwise, if you wait for the oxygenation to worsen, the lung infiltrates to worsen, by this and COVID we have seen, they deteriorate very rapidly. Within 24 hours, the patient is close to death. So it has to be a very early calculated decision to initiate it.
With hydroxychloroquine, is there any evidence of HCQ having any antiviral activity against the coronavirus?
So a very good question. Basically, we know the coronaviruses enter the human body through some receptors. These receptors are known as ACE2, ACE2 receptors. So the virus has to bind to ACE2 receptors to gain access to the inside the human cells. It has been shown previously that hydroxychloroquine has inhibited ACE2 inhibitors in previous coronavirus infections. So the rationale and the hypothesis to use it is that it will be inhibiting the coronavirus 2, which is the COVID receptors also. So this is the hypothesis on the basis of the previous experiments. So the answer is yes, because the ACE2 receptors are present in the lungs also, in the heart also, kidney also. So there is a hypothesis that yes, it tends to inhibit the receptors in these organs also.
Okay, but not antiviral activity though.
No, it inhibits the entry of virus inside the cell.
Thank you, Dr. Debashish Gupta and Dr. Saxena. You have actually cleared the entire area of clinical practice and brought us all updated. So we are very, very grateful as this global COVID-19 network. Thank you. And please stay on if you are able to. But if you are a busy clinician, obviously, then you have other things. You can listen to Ernesto comes from University of Pittsburgh, or rather he is at the University of Pittsburgh as professor of infectious diseases and microbiology. He works with Dr. Don Burke, who is one of the world's best known virologists, knowing exactly from HIV/AIDS days and Ebola days. So he is going to talk on the roadmap to the vaccines against COVID-19. And I think it'll be good to get an update of what is the realistic roadmap. So it's over to you, Dr. Ernesto.
Thank you, Dr. Hira. It's a pleasure to be here presenting and also listening to all these excellent presentations. I do think that a vaccine will be the best solution for controlling this pandemic. I think we will live with this disease for a very, very long time, and the way to come back to the way life used to be in 2019, you need to have a vaccine. And there are a lot of vaccines being developed, probably more than 100 different vaccines that are being tried and are currently in different stages of preclinical and clinical development. Some of them shows like early signals of immunogenicity that are very encouraging in using very new technologies. So many different types of vaccine formulations have been tried, like from inactivated virus, viral-like particles, recombinant protein, genetic vaccines, either with DNA or mRNA. That's one of the most advanced examples is an mRNA vaccine. Also nanoparticles and some tableted heat inactivated virus that you basically eat for enteric release of the antigens. And you also have live attenuated vaccines using viral vectors like lentivirus, adenovirus. There is also bacterial vectors like bifidobacterium longum and a variety of dendritic cell-based vaccines. There are some other vaccines that have been tried that are not exactly or specific for coronavirus. That is the BCG that may have an impact on boosting the overall innate immune response. There is also the passive immunization, like we just heard, the convalescent plasma, monoclonal antibodies, and also T-cell therapies that are being tried. There is already about 20 vaccines entering phase 1 and 31 that are already in a mixed phase 1-2 trial combined. And these are enormous number of vaccines, and the speed that has been developed from prototype to first in human has been extremely reduced. And normal vaccine development, or at least in our more recent experience, has been taking around 20 years or almost 20 years. And one clear example that I can share the experience is the development of the tetravalent dengue vaccine by Sanofi, Dengvaxia. And you started with that, the discovery of the yellow fever dengue chimeric virus. And from that went to the animal testing, and there are a very large number of different animal tests, which were very successful. And several aspects of the immunogenicity of the vaccine and protection levels in animal challenge and all that were successful as well. And then comes one critical part of vaccine development, that is not only in regard to the biodistribution, toxicology, teratogenesis, all these things, but also the assays to measure the efficacy of the vaccine and to measure the safety of the vaccines. And During this development, in the example of dengue, neutralization or neutralizing antibody titers were the preferred method. And they chose standard generic cells, viral cells, which is able to demonstrate that the serum can block the virus to entry those types of cells. And at that time, there was a strong belief if you have neutralizing antibodies, you are protected. So the phase 1 trials show great immunogenicity, showed safety, a good safety profile, no significant adverse events. On phase 2, they started with, based on the encouraging results of the phase 1, they start immunizing significantly large numbers, including children. And the phase 2 trial was also encouraging to some degree, but also showed that the vaccine was only partially effective. Although that was not sufficient to stop the use of the vaccine, they started a phase 3 trial and combined multiple phase 3 trials and phase 2 trials. In total, they tested the vaccine in about 40,000 individuals. And 2 years later, or 3 years later, they were with sufficient data to show protection and essentially no risk of the vaccine. And the vaccine was licensed in a few countries, and they started rolling out. There was some restrictions or limitations in how the vaccine would be released, and the context was because they saw more efficacy in individuals 9 years older, or 9 years or older. They recommended vaccination only in patients of this age. And then after, by the time the vaccine was registered and distributed, things changed. And then the normal aspect of it, especially with new vaccines, you have a very strict follow-up guidance on how to use and monitoring specific problems, and they also continue doing some phase 4 studies. And that's a point that I want to highlight. Here you see a graph, and you see 4 lines. 2 are dotted lines. The dotted lines are from individuals that received the vaccine, and the continuous lines are individuals that receive placebo. And in this case, the red lines are individuals that were seropositive for dengue at the time of immunization. What it means is that they had dengue at least once before they took the vaccine. And in the other group are individuals that never have been exposed to dengue before, that are the blue lines, and took the vaccines. They were 9 years of age or older, and they never had dengue before, and they took the vaccine. So if you look into this graph, you're gonna see the immunized individuals versus the placebo, and the red are the people that had the primary dengue infection and took the vaccine. Had a huge benefit in this group, more than they had quantified previously. But when you look at the individuals that were naive for dengue and took the vaccine, you see very modest effect up to 1.5 years after the vaccination, and then things start to change, and then you start to see that immunized individuals have now the greatest risk to develop dengue hemorrhagic fever or severe dengue, much more than the individuals that had no vaccination. So in this, I would say it's good and bad news. The good news is that if you had dengue and took the vaccine, you were protected. Uh, However, if you had never had dengue and took the vaccine, you had greater risk. And what does it mean is that after this period, after this date, the way the vaccine is recommended to use requires previous testing of the individual if they have been exposed or not. And some difficulties there are some difficulties in this testing because uh, cross-reaction with other flavivirus, you require an assay that is very specific for dengue and doesn't cross-react with others. And there are a few major points, or 5 major points I want to bring attention to, is that in vitro neutralizing titers show a limited correlation with protection. In this Sanofi vaccine and other vaccines like the one by Takeda, it shows that even if almost 100% of the individuals develop neutralizing antibody titers against all 4 serotypes. The problem was that the levels induced or the lack of proper T cell responses was not able to provide protection. You see also a limited duration. You see that even the titers decay over time. The titers of antibodies induced by the vaccine decay over time quite significantly. And the efficacy was highly dependent if there was previous exposure or not. So, in this, the behavior observed in the immunized group that was naive to dengue, it supports the antibody enhancement theory that I will explain more later. The good aspect of it is that you can use the vaccine if you do proper screening. You could use the vaccine safely and with good results. But the point I want to stress here is that take some time to fully observe the effects of a vaccine. It's not immunizing today and 2 weeks or 3 weeks from now doing some challenge or measuring efficacy after immediately after immunization. You have a lot of in a specific response or innate immune response there that has an impact on the clinical outcome, and it's not truly dependent on the memory that the vaccine has induced. So this graph in the top line is the antibody titers of individuals that took the vaccine 5 years later. The titers are not that impressive. When you look in the placebo group that was seropositive in the baseline, the difference is very little. It's not that big. And when you look to the the neutralizing titers of individuals that that were seronegative and took the vaccine are much lower than the ones that were seropositive. And if you look at the ones that took placebo, the titers are very, very low, or almost neglectable. But these levels were a little bit higher and apparently more capable to induce ADE. So what is antibody-dependent enhancement? What happens is that you have antibodies that can bind the virus, but they are not sufficient to neutralize or kill the virus or opsonize in a way that destroy the virus. So these immune complexes can be captured by immune cells that express the Fc gamma receptor. There is a receptor that binds specifically to the immune complexes. And when this is internalized in a certain way, it ends up increasing the infection of immune cells, and also has an impact on the antiviral responses of the cell. So the antiviral response of that particular cell are reduced, which facilitates the viral replication, and those cells end up being able to produce more virus. So now coming to the COVID-19 vaccine development, everything is being done in parallel. The prototype vaccine to animal testing clinical trial is done almost simultaneously. So you make your chimera, your plasmid or your mRNA or your DNA, and you start animal testing and developing the assays to measure the immunogenicity of the vaccine in the phase 1-2 trials simultaneously. What it means is that you don't take the experience from one phase to the next. You are learning at the same time everything. So in one key aspect here, it's because at this stage, the main parameter you have to judge if the vaccine is being good is actually the assays you use to measure that neutralization, the T cell responses, and they need to be validated properly. And this takes time. You require gold standard, gold-plated reference samples that require excellent characterization and all that. And it takes a time. It's not that these panels are really available. So one way that has also been proposed to speed up the tests is to conduct these structured human exposures, but translating to regular colloquial language is a human challenge. Basically, what you do is to immunize individuals, and then you expose them to the COVID-19 virus and study their outcome. Basically, what is happening is taking individuals from the phase 1-2 trials and selecting a subset of them to do the challenge. And the expectation is that if successful in these individuals, the human challenge, which may happen by next spring, we'll start rolling out the vaccine. And you're gonna need to be very careful at this stage, because in essence, it's still almost like a phase 3 trial, a regular phase 3 trial. And you may start with very, very high risk individuals, like people with 95 years of age or older, with comorbidities, and perhaps healthy healthcare workers that are highly exposed. And you note that from until this stage, you not have even given the proper time to evaluate how long the immune response lasts. And also, there is very little understanding of the immune pathogenesis of the COVID-19 at this stage. So, and after that is that you start licensing and expanding the use and for general population, which may be essential to actually control the outbreak. So at this stage, the correlates of immunity or the mechanism of how the immune system can protect you against infection is still limited, the understanding of this, and much less what is causing the disease. Like we had very clear examples mentioned in the previous presentations about the microthrombos, these cytokine storms that are involved in the pathogenesis of the disease. So at this stage, it's very important to identify the epitopes and that are correlated of immunity, to identify the antibody subclasses and kinetics of the virus. So another aspect that for COVID-19, mucosal immunity may be essential. And we need to study this profoundly. We still don't know. And also to investigate the possibility that antibody-mediated enhancement it could be occurring in COVID-19. We also need to study the role of T-cell responses. The same identify T-cell epitopes, characterize the types of CD4 T helper responses and CD8 responses. So the mechanisms associated with pathogenesis need to be better understood in terms of cytokine storm or complement activation. What is causing that? There are several articles that have reported antibody-dependent enhancement against coronavirus to SARS-1 and to feline coronavirus. They have been shown to cause in these animals peritonitis. Monoclonal antibodies have been shown to cause antibody-dependent enhancement. Has been shown to occur also in macrophage, in alveolar macrophages and human monocytes. In the case of coronaviruses, has a different aspect than in dengue. In the coronavirus, the antibody-dependent enhancement has also been demonstrated in homotypic fashion. What it means is that you have immunization or infection by one antibody, but by one virus, and you end up having a worse outcome after reinfection by the same virus, which is different than dengue because you change serotypes. So the mechanism here may be slightly different. And the same or similar mechanism has been shown for SARS-1 as well. So how it works in COVID-19. So you have this the virus particle, and you have antibodies that can completely block the spike protein from binding to the ACE receptor and entering the cell. However, there are other possibilities that antibodies that do not neutralize the virus and form these immune complexes and actually generate the immune complexes just like the dengue example, and that can be captured by the Fc gamma receptor and facilitating the infection of those monocytes and macrophages. There are other types of mechanisms that can happen as well. Once the infection and the virus is incorporated in a multimeric fashion, those cells or dendritic cells, they, in addition to facilitate infection, it also inhibits the innate immune response, the antiviral response, and also you start to produce this enormous amount of pro-inflammatory cytokines, generating an imbalanced response. And here is an example where naive serum is presented, is administered at different concentrations, and you see a constant rate of infection. When you use an anti-spike protein serum, you can see protection at high concentrations that diminishes as the titer, the amount of antibody diminishes, reduced. And by once the concentrations get low enough, you actually have several fold greater number of cells infected. So there are two factors that interferes with the, let's say, the interactions on how the ADE occur. In the case of heterotypic antibodies like dengue 1, dengue 2, there is the effect of the affinity, because the antibodies against one virus don't necessarily are identical to the other virus, but they are similar and they can bind to that with a lower affinity. So concentration and affinity makes a very big play an important effect in ADE in like flavivirus. In the coronavirus, you can have, I would say, the two situations as well. But what has been demonstrated so far is the homotypic, that is mainly dependent on concentration of antibodies and not necessarily on the affinity of that. And however, we cannot rule out the heterotypic ADE, because although the similarities between the regular human coronaviruses and SARS-2 are small or not necessarily, but are not neglectable, the homology is in the range of 50%. Although the homology is not that great, if you have very, very high concentration of antibodies against endemic virus, you could have similar effects of perhaps some degree of protection or perhaps some degree of enhancement. And here, based on different situations, as I point out here, if you have high affinity or high concentration of antibodies, you can completely block the infection. The worst case scenario was when the proportion of antibodies and virus are equivalent, and you can form networks of virus that have not been neutralized but can be easily taken up by cells that infect by cells that express Fc gamma receptor. And the other situation is that you have such low affinity and low concentration that the presence of those antibodies are indifferent. So we have to pay attention to that. Here is the profile of the immune responses to natural infections. Here, it's relatively small. We have very few studies at this point showing the kinetics of the antibody responses. In this case, for IgM, these are all PCR confirmed cases. You have the majority of individuals didn't produce IgM. A fraction of them produce very low levels of IgM. And I would say less than 30% produce high levels of IgM. I would say the fact that many individuals never elicit IgM response, to me, it's a bit concerning for two reasons. Why is that? It's because we are not having enough activation of naive B cells, or is it because what is happening is that we are boosting the memory B cell response to previous exposure to other coronavirus? We do see similar event in dengue. About 30% of the individuals in a secondary infection don't produce IgM. Only in the primary infection, I would say in contrast, in primary infection, almost 100% produce IgM, while in secondary infections, you have about 30% that never does. This is titer of IgG, and the titers here are not impressive. These are not neutralizing titers, and you see around 1 to 20 is the majority. This is borderline cutoff level, and you have some individuals that continue to be IgG negative, but the vast majority was a low level of neutralizing antibody in natural infection. And this we are counting only less than 2 months after infection. Only a smaller group actually produced high levels of antibodies. So in the context, in this context, I want just to remind that the closest is the antibody level in the serum to the dilution that leads to the peak enhancement. What it means is that, let's say, if I dilute you have a titer, IgG titer in your serum, let's say 1 to 40, and then let's say these titers drop in half, and by the time they drop in half, they started already enhancing. And this would be a very high risk situation as compared to a situation that you would have to, the antibody titers would have to drop, let's say 100-fold to actually reach peak enhancement. So how you can at this time reduce or at least start investigating the risks involved in the COVID-19 vaccines. My first suggestion is also based on the dengue experience. One of the factors that was afterwards considered that was misleading during the vaccine development was the use of viral cells as the standard to measure neutralization. It's essential to use more biologically relevant cell types. In the case, is using human, lung, or epithelial cells, or any kind of pneumocytes. And the viral cells are kidney cells that they are used because, or the viral E6 is used mainly because express high levels of ACE2 receptor. But it's not the primary cell target that is involved in the infection. So cells from the respiratory system, either mucosal or lung, are essential to have that. And especially cells that express different types of FC gamma receptors or FC RN, that it's another type of receptor that is involved in transport, in transcytosis in the placenta, but it's also present in the lung. Another aspect is that the human challenge studies should not be necessarily restricted to the individuals that developed the highest immune response or at the peak of the vaccine response. It should be also conducted in later time points as the immune response decays, or also test the challenge in individuals that received a low dose of the vaccine or uh, produce low levels of antibodies in response to the vaccine. This is a complicated ethical question. However, would be also unethical to release a vaccine to the wide population without knowing that it may be 6 months or a year later, you could actually be setting up those people to a more severe form of the disease. So uh, currently, I have been focusing my research in trying to understand the mechanisms of immune pathogenesis of COVID-19, especially the role of antibodies against the human coronavirus, in comparing the early immune response to COVID-19 and other coronavirus to the clinical outcomes, and also studying the antibody-dependent enhancement that this serum can cause, and also characterize the complement activation at early stages. So with this, I hope to be able to develop ways to access the safety or potential or identify risks, or at least to identify ways that I can use to evaluate if the vaccine is efficacious and safe to use. We're gonna need those tools down the road once the rollout will start. So with that, I just come to a few conclusions that there is an urgent need to study COVID-19 correlates of immunity and pathogenesis. We need to develop assays that are equally capable to measure neutralization and antibody-mediated enhancement in ex vivo and animal models. And also we need to carefully design human challenge studies that can address the impact of low antibody responses that will occur after a few months or a year that the vaccine has been administered. With that, I can take your questions.
Well, thank you, Ernesto. It's been an excellent presentation. Lots and lots of complimentary messages that came across. Several of them, like Dr. Saxena and Murutha Sankar, all talking about very well explained vaccine. One burning question that has come across with several questions is what is the time frame, a reasonable time frame for an effective vaccine? Because all that you see in public messages across the globe are everybody's talking about a vaccine without really looking at all these correlates of immunity and all these schematic things that you showed. Would you want to answer that?
It will be an unprecedented vaccine development from the start to roll out, the start of the prototype vaccine to roll out. What, in my perspective, what will happen is that we can have immunogenic formulation or effective antigen formulation by next spring in 2021. Doesn't mean the vaccine is safe, doesn't mean the vaccine is, let's say, how efficacious it is. It's not going to be known by that time. That's why the rollout has to be very, very careful, because it's almost like a clinical, it's still part of a regular phase 3 clinical trial. It's not going to be the typical vaccine development, or it's not the, you have a fixed label of the vaccine with all the explanations necessary for people to feel confident. And we are flying blind. So I think if you can make an analogy again to what happened with the Sanofi dengue vaccine, the government of Philippines released, immunized 1 million children as recommended, above 8 years old, 9 years old, and a few years later, they start to see an increase in severe dengue in the immunized group. So the problem there is that those risks were known, I would say, to some degree. They were not known for sure, and perhaps if there were a more staggered or more conservative release, and I can give the example what happened in Brazil. They released, or at least they started some sort of phase 4 trial in Brazil by immunizing 200,000 people, still a substantial number, but was in a much older population in an area that had moderate to low dengue virus circulation. And in Brazil was not observed increased risk, because vast majority, they were immunizing children with 15 years or older. So similar to this vaccine, we have to be very careful to whom you immunize first, considering very carefully the risk benefit. The person that is taking the vaccine must understand that there are a lot of things unknown about this vaccine. And hopefully, the same way that as we understand what the risks are, we also may be able to develop strategies like the Sanofi did. Okay, if you test against dengue before and you take the vaccine, you are fine. And could be the case, like the vaccine may be used to prevent reinfection first, or some other mechanism that is not related to previous exposure. So I think this is the reality is in this case, the urgency of a vaccine is so big, not only by the lethality rate and the range of number of people being infected, but also because of the economic impact of this vaccine. It is pressuring this bold vaccine development. So yeah, my answer is this, is that in 1 year from now, we will have some sort of vaccine, but we have to be very careful on how to use it.
Well, that's an optimistic note for a lot of our participants to know that something in 12 to 18 months could be on the horizon, but then obviously with lots of caveats there. We have run out of time, and so it's time to really thank all the speakers. We cannot take any more questions. And just a final word of thank you to the Secretariat, especially Camila and Anubrata of Sambodhi, as well as a quick announcement that the fifth webinar that will be next week, next Tuesday, 26th, and that will be at the same time on the topic of country response of Italy. One of the member of the Italian task force to the European Parliament is an infectious disease doctor, Dr. Daniel, and he has agreed to share the widespread epidemic that hit Italy very early, and there's a lot we can learn from that. And then we have a public health specialist from National Health Service of UK to discuss about personal protection, both at the personal level as well as at the workplace and the hospitals. So with that, the final word can come from Camila. Any housekeeping announcement?
Thank you so much to all panelists and participants for attending. And we had an extremely insightful discussion. I think everyone will agree. I'd just like to conclude by announcing the launch of our microsite, the link of which I've shared in the chat box. Do check it out. We have all our webinar recordings, presentations, and other interesting material that you can go through after each webinar. And with that, I invite everyone to attend our next webinar next week. I'm sure it will be very insightful. Yes, that's all. Thank you.
All the speakers, we are very grateful, and over time we will keep reconnecting. Till then, it's goodbye, and thank you so much.